Established treatment protocols for bladder sling health complications involve initial radiological images, including a CT scan, evaluation of the woman's medical record, review by a team of medical specialists, prescribed therapies, and then, when indicated, revision surgery, reconstructive surgery, and ongoing chronic pain treatment. Dr. Hibner emphasizes that in surgery, all of the mesh needs to be removed.
So when I see the patient with mesh injury, I do believe that mesh needs to be removed completely. And that's for basically two reasons. Number one, you can't really tell which part of the mesh is causing pain. It most likely are the arms of the mesh, not the vaginal part of the mesh. But I believe that the entire mesh needs to be removed because, again, you can't really tell. The second, probably even more important reason why the entire mesh needs to be removed is that if you remove parts of the mesh, and don't remove the rest of it may be very difficult to find. So it is much easier to remove the entire mesh in one piece rather than removing it partially and then going back in and trying to find whatever was left behind.
Following mesh removal, if there is a reoccurrence or continuation of incontinence or prolapse, a non-mesh reconstructive procedure might be indicated.
We do other surgeries than the mesh removals. We pretty much perform all surgeries that are for women with pelvic pain. For patients who had mesh removal and now they may have developed urinary incontinence as a result of removal of the mesh or sling, we work with urogynecologists that will now perform reconstructive surgery to help those patients with incontinence. Those procedures are generally done without mesh. They're generally done with patients' own tissues and fascias or using sutures without using mesh, synthetic mesh.
For continued pelvic pain following surgery, specific therapies to treat muscle and nerve pain are initiated or continued, which include physical therapy, Botox injections, vaginal suppositories with Valium, ketamine, and/or baclofen. And if needed, targeted nerve blocks can be performed with anesthetics and steroids.
Most of the patients who had removal of the transobturator sling are very happy with the outcomes, about 70–80% of them. And those are the patients that can regain the sexual activity and daily activities. They may still require some treatments. They may still require some physical therapy, or they may still require muscle relaxants or Botox injections. There is not many patients that do not require any treatments at all.